Dr. Kingman, you've mentioned about the gold standard of prostacyclins. Let's talk about some of the issues surrounding their use for patients, especially in the area of pain management.
Prostacyclin medications are our best medications that we have to treat PAH. They have three great properties. They have vasodilatory properties, meaning they open up pulmonary arteries. They have anti-proliferative properties, which is important to reverse some of the thickening of the pulmonary arterial wall. And they also have antiplatelet properties, which we think is helpful in preventing small blood clots from forming in the pulmonary arteries. And they work better than any of the other medications that we have. The challenge is they also have the most difficult side effect profile.
So it's really a balancing act providers have to do.
It is a balancing act. We want to, in general, we want to give as much prostacyclin as we can, but we don't want to do it so fast or to such a high degree that we cause intolerable side effects. So we are always balancing between improving patients' symptoms as much as we can, but minimizing the side effects that they're having. The prostacyclin medications are all started at a very low dose because of the side effect profile. All of them, whether it's an oral, inhaled, IV, or subcutaneous prostacyclin, we start at low doses and then at intervals, which can range from daily to once a week. We slowly increase the dose until we reach either the highest tolerated dose or we reach a dose where patients are doing much better and that we know that we can stop at that point or hold the dose at that point. The side effects, though, I'm emphasizing side effects, but they're really more prominent during the titration phase. So that can take place over a few weeks, sometimes up to 3 months before we get to that initial goal that we're looking for. And once we reach that goal, we call it the maintenance phase, where we're not necessarily increasing their dose very often. The side effects often get much, much better, if not go away completely. So it's really important to keep that in mind and that the patients are aware of that you may have some side effects or you probably will have some side effects, but they're going to get better, and then you're going to feel better, and you're going to be able to breathe better. And patients do find that their quality of life is much, much better on prostacyclins than before they went on them. If we talk about parenteral prostacyclins, that means that, or we'll talk first about intravenous prostacyclins, or parenteral, meaning given through an IV or continuous infusion. We have epoprostenol, which is the drug that's been on the market the longest. It's the gold standard for the most ill patients. It has the disadvantage, though, of having a very short half-life. The half-life for epoprostenol is only 3 to 6 minutes, and these medications are continuously infused 24 hours a day, 7 days a week. And we think if there's a drug interruption, that patients can experience what we call rebound pulmonary hypertension, where they could get pretty sick if their medication is interrupted. So that 3 to 6 minute half-life is really an important safety concern that we have, and that we have to work very closely to make sure these medications aren't interrupted. The other parenteral prostacyclin that we have is treprostinil, and it's available in an intravenous formulation, much like epoprostenol, where it's infused 24 hours a day. Patients have a central line catheter in their chest and an infusion pump that they carry around. The advantage to treprostinil is it has a longer half-life, so it has a 4-hour half-life. In our particular program, we'll choose this medication especially if somebody lives far away from a medical center. So if they do have a drug interaction, they've got time to get somewhere and get that infusion restarted. The side effects for epoprostenol and treprostinil are the same. I tell patients they fall into 2 categories. There are side effects that are pain, which might be headache, jaw pain, leg pain, sometimes full body aches, back pain. And then there's GI side effects, which are nausea, vomiting, diarrhea, and loss of appetite. And we also have a way to give prostacyclins that's by inhaling them. And there's 2 inhalation prostacyclins that we use in some cases, but I always like to emphasize that they are not as strong, not as potent as the parenteral prostacyclins, but there's a group of patients who are good candidates for this. They're maybe not in overt right heart failure, but they need a little bit more than their ERA or their PDE5, and that's where we usually will look for inhaled prostacyclins. The first one that was approved is called iloprost, and its challenge is that it's dosed 6 to 9 times a day. So you have to have patients who are very committed to taking a treatment about every 2 hours while they're awake. They do get to sleep through the night, but once they wake up, it's every 2 hours. They take essentially a breathing treatment. This has an advantage, though, that it's delivered directly into the lungs. We don't see as much systemic side effects with the inhaled prostacyclins, although we do sometimes see cough. The other inhaled prostacyclin that we have is treprostinil that we were talking about in the subcutaneous or intravenous form. It's also available inhaled. It's dosed a little bit differently. It's dosed in breaths. So patients are titrated up to where they ultimately are on 9 breaths 4 times a day. So it's a little bit easier from a dosing standpoint because it's 4 versus 6 to 9 times a day. So we do have those 2 options for inhalation with prostacyclins. The advancement in the last few years has been the approval of oral prostacyclin options, which has been for many years sought after, and people were very excited about that. I do want to say the caveat that it's very important to not think that oral prostacyclins are a replacement for parenteral. They're more in the category of inhaled therapies where patients may benefit from a prostacyclin. They have been shown to decrease time to clinical worsening, and they're used earlier now. I think patients are getting prostacyclins earlier now because there are these oral formulations. We have 2. Treprostinil, again, is available in oral formulation. Initially, when it was approved or studied, actually in the clinical trials, we were dosing it twice a day and quickly learned that the side effects were very difficult with twice-a-day dosing. So now the standard really among experts in pulmonary hypertension is to dose it 3 times a day, starting at very, very low doses and increasing every 3 or 5 days by very, very small increments, 0.125 microgram increments. And that's dosed until patients are either not able to tolerate the side effects by going up anymore, or they're doing much better and we don't have to go up on the dose. Selexipag is in the prostacyclin pathway, not technically a prostacyclin, but it's a prostacyclin agonist. So it has the same effects as prostacyclin and the same side effects as prostacyclins. It's dosed twice a day in 200 microgram increments, and we start at 200 and then every week go up by 200 micrograms twice a day until the side effects are too severe or they reach 1600 micrograms twice a day, whichever comes first.
And then we move on to the subject of pain.
Yes, we'll talk about pain. I think pain and GI side effects are equally as common, but to talk about pain a little bit, one pain symptom that patients on prostacyclins most universally have is jaw pain. And jaw pain is unique to patients that are on prostacyclins, and it's a pain in the jaw, and it is described by patients as what you might expect if you bit down on a lemon. So it's not a terrible thing. It's not dose limiting. It's not something that we say, oh, we're not going to go up on your dose because you're having terrible jaw pain. I don't think I've ever seen that happen. It's also very unusual because it happens with the first bite of the meal. So they take the first bite and then it's okay. So very odd, unusual side effect. Some patients find that they do better if they chew gum all day because then they don't have that first bite experience. But again, not a limiting thing. All of our prostacyclins and actually all of our medications cause headache in some patients because it's a vasodilator. It opens up blood vessels in the brain and can cause headache. So we have some tricks that we use for that. We recommend Tylenol as the first option. And then sometimes we'll have patients take Tylenol an hour or 45 minutes before their dose. That seems to really help minimize or relieve the headaches. Leg pain is pretty common with prostacyclins, especially when patients have been standing up for a long time. They say if they're up on their feet, that they can get foot pain or leg pain. And then we have some medications that we use to treat leg pain, and usually can work through that, although it can be dose limiting in some cases. And then there's other patients who hurt all over and they just have this generalized, body aches or back pain. And I will say one thing that is important to know is if patients already have pain somewhere, putting them on a prostacyclin oftentimes accentuates that pain. So if there's somebody who has knee problems, they might end up with a little bit more knee pain than they had before. But what we do is really try to be proactive in how we address these side effects so that we can have a plan, we educate the patient on the plan, and do things that can help minimize this pain and keep people on the therapy that they really will benefit from.
Excellent, doctor. Thank you very much.
You're welcome. Thank you.